It is both a pleasure and an honor to introduce Dr. Benny Litwin this afternoon. Dr. Litwin has over 30 years of experience in a variety of healthcare, administrative, and academic settings, and is currently Associate Professor of Physical Therapy and the Director of the Transitional DPT Program at Nova Southeastern University in Fort Lauderdale, Florida. Dr. Litwin's teachings and research interests include cardiovascular and pulmonary physical therapy, cultural diversity and gender issues, organizational behavior, communication, and collaborative group processes. She holds a bachelor's in physical therapy from the University of Buffalo, a DPT from A.T. Still University, a MBA from Barry University, and a PhD in conflict analysis and resolution from Nova Southeastern. Dr. Litwin has published peer-reviewed journals and presented original research at numerous international, national, and state conferences. Welcome back, Dr. Litwin, to physicaltherapy.com, and thank you for sharing your expertise with us today.
Hello, I want to welcome everybody, and I want to say I'm delighted to have you here with us today, and as a way of just getting to know you a little bit better, if you could just let me know what kind of a setting you're in. How many of you are in an inpatient setting? Okay, maybe nobody's in an inpatient. Oh, one. Okay. How about outpatient? How about nursing home? Okay. And how about rehabilitation center? I might have missed something, but those are pretty much the general ones that folks are in at this point. And actually, regardless of the setting you're in, I ask that because regardless of the setting you're in, every patient, from my perspective, is really a pulmonary patient. Every patient has at least one lung. I always like to say everybody has at least one heart and one lung, which makes them all sort of cardiopulmonary kinds of patients. And so what we're going to talk about is looking at patients from the perspective of, you know, what does the pulmonary system have to do with PT and how does it impact your treatment plan? Because regardless of whether it's a primary or secondary diagnosis for a pulmonary problem, everybody's going to have a lung, and so therefore that issue is going to be important for everybody. So when we look at the objectives of this, what I'm going to try and do in today's session is look at some of the pulmonary function and physiology and try and make that interesting. I know it's not always the most exciting topic, but look at it from the PT perspective, looking at some of the medical diagnostic tests, pharmacology, labs, and radiographs. I've got some websites here, some links that unfortunately we're not going to be able to access today, but I do encourage you to please look at those because those sites can be very, very helpful in helping you identify some of the things that we're going to talk about today and fill in some of those blanks. All right, so the key concepts we're going to look at, and some of this, I apologize, may be a review for you. Hopefully that there'll be some new insights as we go along. I'll try and make it as relevant to PT practice as possible. But what we're going to be talking about are the mechanics of breathing, looking at the muscles of breathing, compliance, and elasticity. Going to do a very, very brief overview of pulmonary pathology, sputum analysis, pulse oximetry, pulmonary function tests, arterial blood gases, pulmonary ventilation perfusion, and diffusion tests. All right, so when we look at the mechanics of breathing, we have the inspiration, the expiration. The inspiration is contraction of the diaphragm and external intercostal muscles, where the diaphragm moves out, the ribs flare out, and you can see this is a very primitive diagram of how that action occurs. The important part here is that as the ribs move out and the sternum moves upward and forward, you cause a difference in the air pressure in the thoracic cavity. So that's bringing the air in as you have more space for that air to come. And the expiration, the diaphragm relaxes, it rises up and more or less pushes that air pressure out. And so again, there's some very, very good links here, and I encourage you to look at that. The second one in particular particular shows you a really good overview of the gas transport system. And I think that's important for you to understand. I'm going to try and discuss that briefly if we have a little bit of time later on. But I do encourage you, please, to look at both of those, because I think they'll help show you visually what we're talking about. The muscles of breathing, there's the external intercostals, the diaphragm are the primary muscles for inspiration, expiration, internal intercostals, and the internal external oblique, transverse abdominis, and then of course your accessory muscles, sternocleidomastoid and scalenus. And the reason I put this in there as a review is just so that you realize many times patients have muscle weakness, and it may be in a particular area, or it may be diffused throughout the abdominal musculature. But again, to try and pinpoint really where is that imbalance coming, and how is that pathology, particularly musculoskeletal pathology or disuse, how might that be impacting what you're doing with the patient and their ability to oxygenate. The mechanical properties, including the compliance of the lung and the airway resistance, again will impact that airflow and how much oxygenation the patient's going to have available for them during the treatment. So when we talk about compliance, we're talking about this distensibility. How much can that lung actually expand, and what is the recoil? How much will it come back? If you think about a rubber band, when you stretch it and when you let it release, the thicker it is, the harder it is for it to expand, and it loses its flexibility somewhat when it's very thickened. And so when you think about what happens with either over-compliance, when it's stretched out, it's the same thing as with a rubber band, it's not going to recoil very well. So with the muscles and the lung capacity, the mechanical property, loses its ability to recoil, which again, it needs to do that to get that air out. So you start thinking about how much it can expand to get the air in, that's the distensibility of it, and how much can you come back. All right, when we talk about airway resistance, again, this is dependent on the speed of the airflow and how much pressure is required to drive air through the airway. So with pathology, you get increased resistance, and sometimes that flow can become very aggressive as it comes through in through the airways and become problems. So the distensibility, the airflow itself, all of these provide resistance, and it sometimes makes the breathing inefficient. And you'll hear me use the term work of breathing very often during this presentation. So all of these will contribute to the patient's increased work of breathing, which makes it a very inefficient system for them. The pulmonary function measures are those things that we use to look at how well the pulmonary system is actually functioning. It measures the integrity and the function of the system, and it looks at the pulmonary mechanics, lung volumes, capacities, ventilation, perfusion, and the diffusion. So just to review, and this is hopefully a review for you, I'm going to go through this fairly quickly, but this becomes very important when we start to look at what we're going to do with our patient and our treatment plan. Is it a problem of inspiration, or is it a problem of expiration? Where is the air getting trapped, or is it getting trapped? And what is the problem? And those are the kinds of things that we can adjust our treatment to meet the patient's needs. So, and I've got the visual. I know as PTs, we're usually very visual learners, so I'm hoping that this is coming through clearly for you. But let's see if we can do the pointer here. So when we look at tidal volume, you can see that's the normal air that comes in and out, sort of like a tide coming into the ocean. That's at resting, inspiration, and expiration. The internal reserve volume, inspiratory reserve volume, that's the amount of air inspired when needed, and you can see that's over here, and that's greater than the tidal volume. That's what's left when you take an additional inspiration as you need that. The expiratory reserve volume is that amount that's expired after tidal breathing. So when you look at this, this is the additional air we can take in, and this is the additional air we can get rid of. The reserve volume, the residual volume, that's what's left after the expiratory reserve volume. That's what remains in the system. All of these together are called total lung capacity. Now, when we start to talk about capacities, that's a combination of more than one volume. So when we look at the inspiratory capacity, we're looking at the tidal volume plus, here we go. Here's your inspiratory capacity. That's your inspiratory reserve volume plus your tidal volume. And then you've got your functional residual capacity. That's your expiratory reserve volume and your residual volume. So you see those two together. When you look at your vital capacity, which is here, okay, that's what you do when you do a forced vital capacity, maximal inhalation with a maximum exhalation. And that's your vital capacity. When you put all of these together, your total lung capacity, tidal volume, inspiratory reserve, expiratory reserve, and residual volume, that becomes your whole total lung capacity, which is here. Okay? And hopefully that's the sum of all volumes. This will all make sense when we get into some of the measurement systems that we're going to look at. Okay? So as a way of further clarification and definition of these, the tidal volume, which is very often abbreviated V with a little t, is a look at the respiratory volume. Let's get our little clicker back up there. All right, so the tidal volume is a look at the respiratory volume and the minute ventilation, which is typically about 400 to 700 milliliters. In a restrictive disease situation, we're going to talk about what restrictive disease is. This is usually decreased, that tidal volume, and it's because the whole thoracic capacity is small in that restrictive disease, so you have less in and less out. Your respiratory rate, which is sometimes written as a small f or RR, which is probably what we're more used to seeing, that's normally 12 to 20 beats per minute in adults. When you exercise, that does increase. But it can also increase when there's a hypoxic situation, a hypercapnia, which is an increased CO2, an acidotic situation when there's increased dead space volume. So if your respiratory rate is going up disproportional to the amount of exercise, you start to look for some of these other things that might be occurring. The minute ventilation, that's the amount of air expired in a minute. And so that's usually 5 to 10 liters in a minute. And again, that increases with the hypoxia, hypercapnia, acidosis, exercise, anxiety, and the increased dead space. It's going to decrease with the decrease in hypocapnia, which is the decrease in the CO2, and alkalemic, a base state, with neuromuscular disorders when there's ventilatory impairment, or if there's a respiratory center depression. The minute ventilation is a primary index of ventilation when you look at that in combination with the arterial blood gases. So when we look at these volumes and capacities, generally speaking, in restrictive disease, we look at that as a space-occupying lesion. And you can think of that, and that could be any number of things. That could be a pneumonia, it could be edema, fluid in the lungs, atelectasis, fibrosis, a pleural effusion. All those things that take up space in the thoracic cavity is going to prevent those lungs from inspiring and expiring. So what you end up is, and I'm going to show you the next slide because I think it makes more sense here. If you look at this one, this is more of what I like to call the mini-me. The one on the right where it says restrictive, you'll see it's smaller total lung capacity, smaller vital capacity, smaller residual volume. Because the lungs can't expand, there's less air coming in and less air going out. So you have small capacities and small volumes. Next to that, in the middle, is the obstructive. And what you have here is generally big, inefficient lungs. So you have a bigger total lung capacity, and if you look at the residual volume over here on the right, that's much larger, and that's because of the air trapping that occurs with the obstructive diseases. What you're going to see is the vital capacity may not all be that much different, but it's the residual volume that's making this a big inefficient lung. And certainly on the left here is the normal lung. All right, so now you've heard me talk about restrictive and obstructive, and I'm going to spend just a little bit of time on these, not a lot, because this could be, 3 or 4 lectures in and of itself to talk about the pathology, but I want to give you enough of an overview that all of these tests and measures make sense. So these are normal lungs that we're looking at here. Okay, and we're going to start with what I call restrictive lung disease, and this has been a way historically of dividing the lungs into compartments, so restrictive and obstructive, and there's a lot of situations where these overlap or there's combined pathology in a given individual. But for purposes of understanding from a treatment perspective, we're going to concentrate on restrictive and obstructive. Although in some of the new texts you may not see it this way, I think it's a little bit easier way of looking at it. So you'll see this abbreviated as RLD. And what I'm talking about as a small lung, or it's not technically a small lung, but it has smaller capacity of getting that pulmonary ventilation in because of the size of the cavity. And so when we talk about it because the expansion is diminished. And this can refer to any number of different kinds of situations. And it could be because of paralysis, it could be because of scoliosis and bony deformities, it could be because of a tumor, but it's something that creates a change in the amount of space. So we call it a space-occupying lesion, although it's not necessarily a tumor, but the movement of the cavity is restricted so that the amount of air coming in and therefore the amount of gas available for exchange is decreased, both in and out. And it can be a pulmonary system, but as I said, it could relate to any system in the body and may result from trauma, medical intervention, things like radiation. But it very often is something that's affecting the parenchyma of the tissue and causing a toxicity, resulting in a toxicity or a fibrotic situation in the lungs. So what do we have? If there's fibrosis, we're going to have a decreased pulmonary compliance, decreased lung and or chest wall compliance, where the lungs become stiffer and they can't expand. And so that when we talk about fibrosis, that's what we're talking about. So that there's more pressure needed to expand the lungs to get the ventilation in. And so think back to what I said before about that work of breathing. It becomes that much harder as the chest wall compliance is much lower. If you look at the picture on the right-hand side, it's easy to see that that right-hand lung is much darker and does not look like, well, that's the left hand. So facing you, it's the right hand, but it's actually the left lung. So you can see the difference between those two lungs, what a fibrotic diseased lung looks like. So when we talk about that work of breathing, we're talking about respiratory rate increasing, and the tidal volume decreases to try and offset that respiratory rate increase so that you end up with a very rapid shallow breathing, and the individual very often has to rely on accessory muscles and the diaphragm to get the satisfy the need for oxygenation. So what do these folks look like? Well, they usually have a dyspneic state. With any even minor activity, you're going to see that increased respiratory rate, and even at rest as the disease progresses. You're going to see a dry, irritating, non-productive cough, very often a wasted, emaciated appearance. You can see this individual on the right-hand side of the screen. That's somebody who it takes an enormous amount of work just to get food and to eat, and so the caloric requirements to meet that work of breathing takes at least a 12-fold increase, and so very often it's such an energy expenditure for them to eat that you see them wasting and that emaciated appearance. You'll also see clubbing of the digits, and I put a picture of that up on the top of the screen so you can see what that looks like, and that's related to the decreased oxygenation of the tissues. I gave an overview of all the various different kinds of etiology that might even be considered as a restrictive lung disease. It's not a disease in itself, it's really an entity that occurs. But you can see this goes from pregnancy, which is really not a disease state, it's a normal state, but what's happening in pregnancy as the fetus grows larger and larger, it puts increased pressure on the diaphragm, and so that as that pressure rises, that decreases the space in the thoracic cavity. So typically, we think about these kind of diseases with pulmonary or cardiovascular, but you can see it covers the gamut from neuromuscular, and we talked about metabolic. Obesity is certainly can affect breathing from a respiratory restrictive lung perspective. So what I encourage you to do is to look at your patients regardless of what the primary diagnosis is, so that you can say, is there something impacting the breathing, and can this person actually get adequate oxygenation? Because the issue is always, is there enough oxygen supply to meet the demand? So the other things that I throw out here, although it's incorporated in the previous slide, some of the things in particular to think about are some of those post-op kinds of patients where they may not be able to take deep breaths because of pain or because of imbalance or asymmetry, things like scoliosis for sure. Amputations take a tremendous amount of energy for people to walk when they lose a limb. And certainly in normal aging, I'm going to spend a few minutes talking about normal aging because it is a normal process. We all hopefully will age over time. And so what we look at is a very slow and insidious kind of impact on the pulmonary systems, and this is all impacted by what's going on in our environment. Pollution, smoke, cigarette smoking, all of this will decrease the compliance. So that little arrow is down there for compliance, and you can see with the transfer to the slide, it moved itself a little bit, but your decreased compliance in the lung actually begins as early as age 20. So by the time you get to your 60s or 70s, there's a lot of functional changes in the lungs. Now, can normal exercise and keeping fit help to delay that a little bit? To some extent, yes. And so there are clearly some situations that we can do. And so, just because someone's in their 60s and 70s doesn't mean that they're going to have pulmonary impairments, but be aware that those processes do start to change. Maximum ventilatory, that's the maximum voluntary ventilatory capacity, and that declines. So by age between 30 and 70, that ventilatory effort, that maximum ventilatory effort, which is the maximum amount of gas that a patient can move in a minute, that's going to decline between those years 30 to 70. It's a little bit lower for females than males, and you'll see for most of the pulmonary measures that the normative rates are related to age, gender, size of the person, because usually the bigger somebody is, the larger their thoracic capacity is. And I said gender and ethnicity also may impact that. Also, as part of the aging process, you have bony changes, and that's going to impact and decrease the compliance of the chest walls, just the rib cage itself, again related to increased work of breathing. And that is associated with decalcification of ribs, the possibility for increased rib fractures, pathological rib fractures. So again, you have to be careful. What is that rib fracture going to do? The patient's going to be in pain, they're going to be splinted, they're going to have less ability to expand those lungs, and again impact their work of breathing and their ability to perform functional things. So you have the arthritic changes, you have kyphosis. Very often you'll see an increase of the anterior posterior of the chest, the barrel chest, which you'll see in the obstructive diseases as well. And without good upkeep on wellness and fitness, you're going to have strength and endurance of the respiratory, inspiratory muscles in particular gradually decreasing.